Everyone, and sorry, I'll start again. Good afternoon, everyone, and welcome to this May 21st, 2024 version of the Office of the Healthcare Advocate's Lunch and Learn session. My name is Sean King. I am the acting healthcare advocate for the state of Connecticut, and I am here to present to all of you some of the legislative updates that resulted from this past legislative session here in Connecticut. I also have a couple of short updates from the federal regulatory level as well. All of these items are relevant to our work, are important to folks here in Connecticut who are trying to stay up to date on issues related to healthcare insurance coverage and healthcare access. So again, the Office of the Healthcare Advocate, we are your consumer advocacy agency here to provide education and assistance to consumers who are having issues with their health insurance, want to learn more about health insurance and how it works, and looking for help getting access to healthcare and healthcare coverage. So the first legislative change, and I should preface all of this briefly by stating all of these laws have been passed by our General Assembly. They're still awaiting signature by the governor to fully enact them into law, but we have not heard of any signals that the governor may be contemplating a veto of any of these. So we're fairly confident that all of these will become effective on the dates that I indicate as we go through these slides. So the first one I want to talk about is kind of a big deal, Public Act 24-6, which resulted from Senate Bill 395, an act concerning the reporting of medical debt. Here in Connecticut, the reporting of medical debt to credit reporting agencies like TransUnion and Equifax, to our knowledge, has not really been a broad common practice, but it probably happens from time to time. As a result of this new law, effective July 1st, 2024 of this year, so in about a month or so, healthcare providers will no longer be allowed to report medical debts to credit reporting agencies. So anybody who may owe a provider for a service that they got, you found yourself hospitalized and you have a big bill after that, the providers and their collection agents can still pursue payment for those services, but they cannot report those debts to a credit reporting agency. So that's an important consumer protection that's forthcoming here in about a month or so. One important thing to keep in mind, if you do pay for those medical services using a credit card, that credit card company can still report that debt. It's a credit card debt and not a medical debt in that situation. They can still report that to a credit reporting agency. So one distinction to keep in mind. One other important thing to remember is that if a provider violates this provision and does report that medical debt, any part of that medical debt to the credit reporting agency, it becomes void. They can no longer collect it from you. So really important consumer protections starting in July. The next new law I wanted to mention is Public Act 24-19. This came out of a fairly large omnibus type of bill, Senate Bill 1, an act concerning the health and safety of Connecticut residents. There are a lot of provisions in this bill that pertain to various aspects of our public health structure here in Connecticut. Some of the more important ones I wanted to highlight on this Lunch and Learn include sections 18 and 19. Those become effective January of next year. It's a new mandate for fully insured health plans in Connecticut. Requires insurers to cover coronary calcium scans. Next, section 32, as well as section 40. These will impact what is known as the utilization review programs that insurers use. These are the prior authorization type of activities, as well as post-service activities to determine medical necessity. The starting in January of 2026, so not next year, but the following year, they're giving the insurers some lead time on this, but the new law redefines what's known as clinical peer for purposes of these utilization review activities to be limited to clinicians with the same specialty as the treating clinician. So the current law says that they can use somebody of the same or a similar specialty. The new law is going to require them to have a same specialty. So just kind of a description of how that works right now. If you're looking for a cardiology procedure, for example, the insurers can use probably any kind of an internist or somebody with a different subspecialty than cardiology, but they happen to also be an internist. Cardiology is a subspecialty of internal medicine. So currently they would be able to use an internist to conduct that utilization review, that peer review activity. Starting in 2026, however, they will have to use a cardiologist if it's your cardiologist who is recommending this procedure that requires prior authorization. So they have to use somebody with the same specialty going forward starting in January 2026. So this is an important new change. It's going to require insurers to make sure that they have the right clinicians on their staff to conduct these utilization review activities. Then it's going to instill a lot more confidence in the results of those utilization review activities when somebody knows that it's another cardiologist, for example, who has reviewed the request for their cardiology service. And then lastly, Section 40 encourages hospitals and other providers to collect data regarding how much time and energy their staff are spending on these utilization review activities. That data collection hopefully will then be used down the road so that policymakers and others can have a better understanding of what is the value of these utilization review activities. Is it really something that is effective in mitigating overall systemic costs, or is it something that's just creating additional burden on providers and not really yielding any positive outcomes on a systemic level? Next is Public Act 24-58. This came out of Senate Bill 308, an act concerning wheelchair repair requirements. This deals with an issue that came up during the previous legislative session where the legislature wanted to set up a task force and have a study done on some frequent complaints that legislators and agencies were receiving about wheelchair repairs being done in an untimely way. Following that study and the report that came out of that, the legislature passed Public Act 2558 to address some of those issues. Sections 1 and 2, beginning July 1st of this year, require wheelchair suppliers to repair wheelchairs in a timely way, including the timely ordering of parts, and to report to the Department of Social Services data regarding various wheelchair repair activities. So the timelines, the deadlines for some of these activities involved in getting wheelchairs repaired or set forth in the statute, anywhere from a day to a few days for the wheelchair repair company to respond to a phone message, to make contact, to go and visit the individual's home, to assess the need for repairs, assess the home situation, to ordering parts. All of those deadlines are prescribed in this new law, with an eye towards making sure that folks who use wheelchairs to ambulate will have those repairs done in a timely way when they're needed. This also, Public Act 2458 also designates the Office of the Healthcare Advocate, our office, to receive complaints and collect data and report on that data regarding any issues of untimely repairs and other things related to wheelchair access and wheelchair repairs. either through commercial insurance, through Husky, or through other means. It places restrictions also, section 3, 5, and 6 places restrictions on Medicaid Husky as well as commercial insurers from requiring new prescriptions or prior authorizations before a wheelchair can be repaired if that wheelchair is less than 5 years old. And lastly, section 4 of this law establishes a wheelchair repair advisory council to continue to monitor this environment and make sure that not only are these rules being effective in decreasing the amount of time that it takes to get wheelchair repairs, but also to recommend any future changes that might be needed to make sure that folks who are use wheelchairs or wheelchair bound are able to use those devices, especially after they maybe suffer a malfunction and have the need for a repair. The next new law is Public Act 24-81. This grew out of House Bill 5523. Long name here, an act considering allocations of Federal American Rescue Plan Act funds and provisions related to general government, human services, education, the biennium ending June 30th, 2025. This is another large omnibus bill, otherwise known as the implementer bill, that is passed every legislative session to try to capture a lot of things, big and small, that the legislature was able to package into one bill and pass through. So some of the important provisions of this one: Section 15, effective immediately, appropriate $7 million to the Department of Social Services to provide for rate increases for providers of behavioral health services for children. This grew out of a study that was done by DSS, actually just the first phase of a longer study that DSS is conducting regarding the rates that it pays to various providers. One of the things that was highlighted as a result of that phase 1 study is that providers of behavioral health services for children could use a little bump in the reimbursements that they get from Husky. And so this $7 million attempts to address that problem, at least in part. Another section of the bill, Section 38, effective October 1st of this year, is not as favorable a change, I think, to especially not Husky beneficiaries, but overall to residents of the state of Connecticut. It actually reduces the income threshold for parents and caretakers to qualify for Husky A benefits, drops that threshold from 155% of the federal poverty level to 133% of the federal poverty level. So unfortunately, as a result of this change, starting in October, there will be fewer parents and caretakers who will qualify for Husky A. They still may qualify through the Cover Connecticut program or through Access Health for a qualified health plan with tax subsidies. So there is still something of a safety net for people who no longer who fall between 133 and 155% of the federal poverty level. But certainly some of these folks would prefer to remain on Husky and unfortunately won't be able to after October 1st. Sections 61 and 62 of this bill require DSS to amend the state Medicaid plan to provide for coverage of certain services provided in schools. Things like visits to the nurse's office where the nurse provides some treatment. They're looking to make sure that the state, if they can get some reimbursement, provide reimbursement to the schools, but also receive federal reimbursement for Medicaid funds spent for those activities. Section 64 of the bill, it goes in the opposite direction from the Husky A. So for Husky, not Husky, but the MedConnect program, Medicaid for the Working Disabled program. Currently, the eligibility thresholds for people to participate in that program are $75,000 a year in income and either $10,000 in assets for a single individual or $15,000 in assets for a married couple. Those threshold numbers are going up. So now an individual can earn up to $85,000 a year and still qualify for the MedConnect program, and can have either $20,000 in assets as a single individual or $30,000 in assets as a married couple, and still qualify for the MedConnect program, which essentially allows folks who are disabled but still working to qualify for Medicaid benefits in the state of Connecticut. In addition to increasing these thresholds, however, it does contemplate phasing out all of the income and asset limits for this program over the following 4 fiscal years after April 1st, 2025. So the idea is that by 2029, folks who are disabled but still working can qualify for MedConnect and obtain Medicaid benefits without having to meet any asset or income test. Moving on to sections 93, 94 of the bill, effective this July, for folks who are on Husky. Right now, if they are seeking a prescription that requires prior authorization through the Department of Social Services and its vendors, right now they have 2 hours to make a medical necessity determination. Starting July 1st, they will have 24 hours to make that determination. So it gives DSS a little bit more time to make those medical necessity determinations when somebody's picking up a drug at the drug counter that requires that prior authorization. So it's not for all drugs, just the limited number that require prior authorization. That timeline will increase from 2 to 24 hours. Lastly, sections 101 to 104, effective in January of 2025, modifies a few of the commercial insurance coverage mandates in Connecticut. Some of those mandates provide caps on the amounts that insurers can impose as a co-payment for things like physical therapy and some other things. It modifies those mandates so that those caps are removed if the insurer, or in the case that the insurer is providing a health plan that is a co-payment only health plan. So in other words, it's really intended to allow some creativity in designing of health plans to include co-payment only health plans that no longer have deductibles or co-insurance, but the co-payments that you may need to pay for services can vary quite a bit more than they would now. It's just another way to try to help some innovation and plan design in ways that hopefully can make some of these health plans more affordable and easier to understand for individuals. Public Act 24-110 came out of House Bill 5198, an act concerning telehealth. The important provisions of this bill really just make permanent a couple of things that are already existing law, but were designed to sunset after a certain period of time. Now they're going to become permanent. One imposes certain patient protections from balanced billing for services that are provided via telehealth, and ensures that a patient is aware of the provider's network status, and limits the amount that a telehealth provider may collect from that individual based on depending on whether they're in or out of network. It's kind of similar to some of these surprise billing protections. It sets certain limits either based on in-network contract rates or percentages of Medicare or things like that. So that's one protection. Then Section 4 makes permanent the payment parity rules that currently exist for telehealth. So if somebody receives a service through telehealth, the provider is allowed to collect the same amount for that service from the insurer that they would have been able to collect if that service was provided in person. So that's the payment parity provision of the telehealth bill. So that's all for our new state rules. In the meantime, within the past month or so, there's been a couple of federal rules that were finalized that I wanted to highlight as well. One is the non-discrimination section of 1557 final rule. The Department of Health and Human Services issued a final rule clarifying some of the non-discrimination provisions of section 1557 of the ACA. The new final rule clarifies and reinforces that references to sex in regulations prohibiting discrimination include discrimination on the basis of sex characteristics, including intersex traits, including on the basis of pregnancy or related conditions, sexual orientation, gender identity, and sex stereotypes. Essentially, this rule restores protections for LGBTQI+ individuals and pregnant individuals that had been limited by a prior rule under a previous administration, and therefore expands the scope of activity subject to the protections of section 1557's non-discrimination provision. Lastly, also very recently on May 3rd, Department of Health and Human Services finalized a rule concerning Deferred Action for Childhood Arrivals, otherwise known as DACA. This helps to make sure that DACA recipients are eligible for enrollment in certain coverages through the marketplace. So now anybody who's been designated as a DACA recipient will be considered lawfully present and therefore eligible to enroll in a qualified health plan through Access Health, and can also, if their income within the income thresholds, can receive financial assistance subsidies such as advanced premium tax credits and cost sharing reductions through Access Health when they enroll in these plans. This eligibility provision is effective November 1st of 2024. So can't sign up just yet, but starting in November, if they qualify for a special enrollment period, they can sign up for December 1st coverage. If they don't have a qualify for a special enrollment period, they would still be able to enroll through open enrollment and become enrolled in a health plan starting January 1st of 2025. That was a lot of information. I want to thank everybody for your attention to my presentation. Here in this final slide, we have some information about how to contact us if you have further questions or if you run into any problems, not just related to the information I shared today, but if you happen to have a question or concern about how to use your health plan, you have a healthcare insurance denial from your insurer, you're having trouble accessing healthcare services, please reach out to us, let us know that you need help, and we'll be happy to have a case manager assist you. And with that, we have a few minutes left if there are any questions.